Anybody interested in sharing?
Well, I learned Ashley and I both live in Spokane, so that was cool. So thanks for that. And I realized I should have paid more attention to my science classes because um, perhaps I could have had a better answer about how they all interact. So sorry to my science teachers in the past.
Thanks for that, Erica. Well, we are going to transition on to the next part of our agenda. If you want to share kind of what your element was and why you chose that, please feel free to do that in the chat. And we will transition on now to our legislative update. So I will hand this over to you, Stephanie and Erica. Thank you.
Hi, thank you so much for having us today. We'll do intros and then get going. I'm Steph Budrus. I use she, her pronouns. I'm on the DCOIF Government Affairs team. I'm currently filling in for Mary Sprudy Garlant while she is on leave. I'll pass it over to you, Erica.
Thanks, Steph. Hi, everybody. I am Erica Halleck, she, her pronouns, and I am the Director of Policy and Advocacy with Start Early Washington. And just checking if we have another friend with us. Is Lori Lippold on?
Just joining. Yep, she's just coming on.
Okay, super. Steph and I were hoping Lori could join because she was actively involved in this legislation as well. Lori, is she on? Let's see, I'll scroll. There's a lot of people on. Hi, everybody. There's Lori.
Hi, yes, sorry.
No, don't apologize. I was just going to say, Lori has been, let Lori introduce herself, of course, but Lori has been a longtime advocate for home visiting, I would say her whole career, which is long and illustrious, and working for children and families, and had until very recently been a member of HVAC. She's been instrumental in nearly every piece of legislation passed in Washington state impacting children and families for the last decades, including Senate Bill 6109. So Steph and I thought it would be really important to have her join for this important conversation about this complex bill. So I just wanted to welcome Lori to the conversation and kick it back to Steph.
Thank you. And welcome, Lori. Just as a preview, I was going to kind of kick off here and then I will pass the mic to you for your kind of insight as well, if that's okay. I'll just totally put you on the spot here, but so yeah, so we're here to kind of provide an update, legislative, really focusing on 6109. If we want to kick it over to the next slide, kind of give an overview of the background, some of the ways that DCOIF worked together with bill sponsors in getting this passed, and then we'll really focus in on some of the services and supports, particularly home visiting. But 6109 and 2447 as well, which was the House version of this bill that was in the running for a little while, they were really efforts to try to strike the balance between keeping children safe and keeping families together in response to the ever-growing crisis related to fentanyl across Washington state, fentanyl and other high-potency synthetic opioids. So the bill really attempted to tackle this challenge from three main areas, which were providing clarity in the law, making investments in this network of prevention and intervention services to support safety plans and parents who are really navigating the complexity of addiction, and then also various training and support efforts, including within the judicial system in Washington. So DCOIF worked really closely with partners and the legislature on this bill kind of throughout the legislative session. We all know that substance use alone is not and should not be a reason to remove a child from home. And we know that parents navigating the complexity of addiction really needs support and they need interventions to focus on recovery while keeping their families together. But we also have a really real responsibility to balance the safety of children while parents are navigating kind of these really complicated situations. So a few ways that we worked with the legislature, we were sharing data and kind of nuance around what critical incidents are looking like on the DCYF side, particularly around the very real increases in cases involving fentanyl. And see, that looked something like in 2018, I think we had about 2 cases, and over the last year in 2023, we're up to about 33 cases involving fentanyl and other high potency synthetic opioids, and many of those occurring in children who are under the age of 2. So really helping to help the legislature understand kind of what happens leading up to shelter care hearings, how caseworkers go about determining safety threats, and really also understanding the realities of judicial clarity. So information that we've seen about inconsistencies in the application of law, as well as kind of the non-standard public health guidance in this area, just kind of due to these emergent issues. So really trying to work with that legislature to help them understand this unique situation that we're in, while also mitigating unintended consequences to families. We reiterated time and time again the value of the robust network of services, which ended up being included in this bill, home visiting among them, and how this whole network of really flooding resources into communities are going to be extremely valuable in preventing the need for out-of-home placements, when parents are kind of navigating these realities and we're working on keeping children safe. So I think we really ultimately ended up at a place where this bill does a great job of striking that balance while also infusing resources and really targeted supports for families, to really push those interventions towards where communities are hit the hardest. So that's a little bit of DCYF context. Lori, would you like to add anything else about your gargantuan efforts on these bills throughout session?
Well, I don't know if they were gargantuan, but thank you. And hi, everybody. Thanks for including me in this discussion. Just a couple of things to add. One is we had, and I know folks at DCYF, I saw Vicky Ybarra on today as well, have talked about multiple big changes happening simultaneously, basically, that led to I think in the public, a lot of confusion. I can't imagine what implementing all those as a worker would be like, but a lot of stuff happening at one time. So included was the fentanyl crisis, included the plan of safe care, and included the implementation of a bill passed in 2021, House Bill 1227, that changed the standard for removal to require that they be able to show that there's imminent risk of physical harm. So these are all major things happening. And I think it became difficult to separate them out. So while there was recognition that all these were happening, there was quite a bit of variation on how 1227 was being implemented. It passed in 2021. Implementation didn't begin until July 1 of 2023. And anytime a big policy change is being implemented, there is going to be transition time and probably variations on how it's happening, because we have a lot of different judicial officers, we have a lot of different workers, we have a lot of different attorneys, and people are trying to implement the law, but may not be doing it at the same time in exactly the same way. So that was happening. And we had the fentanyl crisis going on, and there seemed to be a lot of convergence of implementation of 1227 was leading to awful things happening to children. Those of us who were very involved in 1227, including a number of people from DCYF and other places, were seeing it not necessarily as 1227 was causing all these problems, but there was still a lot of confusion about what do we have to show for imminent physical harm, and what are judicial officers requiring, et cetera. So then you have the increase, as Stephanie was talking about, with the number of fentanyl related critical incidents, and it just got to be a big mush. And the main reason I'm bringing this up is because there were also quite a few different perspectives on what needed to happen, if anything, to 1227. And there were those who were very much, we don't need to change 1227 at all. We need to focus on implementation, and we need to provide support services for families so that they are getting the treatment they need, that they have housing, they have everything that they need to be able to address the issues they have. And then there were those on the other end of the spectrum, get rid of 1227. It's awful. And those of you in this meeting are probably somewhere in that, or have heard this kind of thing over time. So I do think that it was leadership on the part of the two committee chairs, Representative Sen and Senator Wilson, in great part, who were very committed to hearing different perspectives. Those of us who had been very involved with 1227 and were focusing a lot on implementation and support services were brought to the table. Our voices were heard. The union voices were heard. Caseworkers, administrators, et cetera, program managers from DCYF's voices were heard. Courts' voices were heard. And I think given it became very clear very early on that something was going to be done, that balance of some policy change with a lot of emphasis on support services was a way to kind of navigate through this. The other thing I want to mention, well, two other things. One is it was a short session, and we typically hear it's a short session. We're not going to do big policy changes in a short session. And that was not the case. And so that was challenging because 60 days and you had what, 2.5, 3 weeks to get bills through and through the first committee. So there was a lot of tension, a lot of yikes, we got to do this, we got to do this, we need input yesterday, all of that. So again, dealing with that dynamic and seeing where things ended up, I think is kind of a testament to people's willingness to keep coming to the table and keep talking about it. The final thing I'll say, sorry to be rambling on, is with the support services, I think a number of people saw if we link some policy change with support services, we will be better able to get funding for support services. And I think that they were successful in getting funding. And I think the funding for the home visiting slots, that increase is fantastic, because I'm not sure that there would have necessarily been an increase in home visiting if there hadn't been this other whole effort underway. And I know, as I would imagine all of you feel like anytime we can get more services like home visiting services funded by the legislature so that families can benefit from the great work all of you are doing, the better. So I'm excited about that. There are other great components of the service part of the bill as well. So anyway, I'll stop.
Thank you, Lori. Really appreciate the context. Just really helpful in kind of understanding the path we went down this legislative session. I have some nuts and bolts kind of I'll cover of the overview of the bill, and then I'll turn it over to Erica to kind of talk a little bit more detail about the home visiting pieces. If we could do the next slide, please. So this bill included changes to the child welfare statute, including defining high potency synthetic opioid to include fentanyl and adding that to the list of reasonable grounds to believe the removal of a child is necessary to prevent imminent physical harm. Also, added this great weight language to give great weight to the lethality of high potency synthetic opioids and the public health guidance that we're to develop with the Department of Health related to high potency synthetic opioids and determining whether removal is necessary to prevent imminent physical harm. Linking there to the full language of the bill so folks can read through that again, and we can go on to the next slide. So speaking of this kind of full range of services and supports that are going to be available in communities now that are particularly hit hard by the epidemic. I was kind of running through here and the funding that DCYF was provided to implement some of these things, including the public health nurse pilot, third-party safety plan participants, contracted slots for home visiting, and contracted slots for childcare. And those are supposed to be kind of targeted to the similar locales, so really infusing resources into those particular communities. Pilot for YV Intercept. So 2 pilots to be set up for that program, legal liaisons for each of the DCYF regions, and then also some language around fentanyl testing strips. We didn't receive any funding for that particular component of the bill. However, the test strips are currently included in DCYF's harm reduction kits. So just a little bit more kind of guidance around that. So that's kind of the big overview of all of the services components for DCYF. And then in addition, HCA and DOH were also directed to engage in some service expansion as well. So children and youth with prenatal substance exposure and the Promotoras program by DOH to stand that up into communities. And then if we go on, and sorry, I'm kind of rocketing through to make sure we can stay on time here. Additional provisions for training and support. So the legal liaisons that will be working between us and the attorney generals on these cases, and then also some enhancements to training and court programs, and then DOH collaborating with us to convene a work group on exposure of children to fentanyl and kind of providing information broadly to folks who are working with children and families in these instances. So I will hand this over to Erica to go into a little bit more detail on the home visiting component of 6109.
Thanks so much, Steph, and thank you to Lori for that great overview. This was a really hard fought bill for a lot of people. I know a lot of people have said this was the hardest bill they've worked on in their career. And I will note too that this is an issue that impacts so many different sectors and the courts, and we've got Department of Health, we've got child welfare, prevention, early learning, you name it. So we can go to the next slide. I know for this group's purposes, we want to talk about the home visiting portion. I think it's important to emphasize that, and thanks Steph for showing the variety of services that were funded. I think it's important to highlight that it is not expected that home visiting is not intended to be a substance use treatment program. It is intended to be one of many services that is provided to families. So I think that's important to highlight. So this is a new way and a new approach that's being tested. So in that we're going to be testing contracted home visiting slots. So the idea is you're going to have existing programs apply. So programs could opt in or opt not to. There was $1.6 million provided for state fiscal year 25. That funding comes from opioid settlement dollars. It is expected to support around 150 slots. The idea behind it with the contracted slots is that those programs that are awarded those slots are provided the funding, and the idea behind it is they're at the go when they get a referral to serve a family, and that they would be provided at the same rate as for existing providers. I can tell you that the intent that we had in that language is, as DCYF is undergoing its rate setting process, we wanted this to not be any lower than what the new rate was going to be. And that's why it was a little vague, because of course this process is ongoing. So there's a previous slide, actually. Can we go back to the previous slide? Oh, it looks like maybe we're missing a slide, but that's okay. Okay, let's go to the next slide then. So the idea is that the DCYF child welfare staff or child welfare side of the house will be developing a referral process, and legislation identified priority families. So families with open CPS cases, families with open FAR or family assessment response cases, and open family voluntary services cases. Not to go too much down a rabbit hole, but I kind of envisioned this a little bit like combined in-home services. Some of you might be familiar with that, where DCYF caseworkers can essentially order various services for families. And I see that home visiting in this case could be something that is ordered for a family. Maybe the slide, there it is. Okay, so we got a little slightly out of order here. So, the idea is to provide the wonderfulness of home visiting that we all know and love, as well as testing a new way of having administration of the services by having predictable funding in a contracted, targeted way. So again, this will be done through a competitive process. And as Steph mentioned, 2 locales with historically high rates of child welfare screened intakes. There are also similar process that DCYF will be undertaking throughout, similar for contracted childcare slots. So this is a similar process DCYF will be undertaking in the childcare space. So this will be an interesting time to see if this is how this goes. I will note that when the governor signed the bill, he specifically called out the power of home visiting. This was something that the governor Inslee included in his budget. It was something that was championed throughout. So the power of home visiting was seen as something that could be one of many tools for families experiencing substance use disorder and families and communities that are experiencing this. So it is very, very exciting. So let's see if we can go to any other slides here. And then we can get to questions, as I'm sure folks have them. I think that might be it. Is that the last slide? Maybe our contact information is on the last slide. So it looks like Allison has a question. Steph, do you want to answer that question? In the chat.
Right, looking in the chat. It took me a second to find it.
Oh, wait, I'm sorry. I did miss something. I knew I missed something important.
Okay.
There is funding provided for the department to provide training. I believe it was $200,000. I knew I was reading something. Training about working with families experiencing substance use disorder. That was an important point. Thank you.
And Steph, this is Laura. Do you want me to take Allison's question in the chat
You said you can take a
about
question.
doing an application?
Yeah,
Yeah,
go
I'm
for it.
happy to do that.
Go for it.
Yeah, Allison, we're not sure yet. We just had our initial conversation internally. Was that yesterday, Steph, or the day before? I don't remember. Losing track of time this week. And we will not, we will engage HVAC in advisement like we typically do at some point along the process, but we aren't quite ready to do that. So we're not bringing that forth today, but if there's things that you all want to share or have any other questions or feedback, you're welcome to do that today, but we're not doing a formal advisement yet on this implementation. So we don't have an answer for you how we're going to do it just yet.
Well, I just know that we have developed some relationships with our local hospitals, and they're calling us when these children are born. And so, you know, I'm just wondering, we're being asked to add that into our regular numbers that we serve, but often these babies are in the hospital longer and they kind of require more supportive services. And so I was just wondering, when you are looking at this additional slots, does it also kind of build in the extra time and commitment that's required to provide that care? So that was just something I was hoping could be thought of as you're developing this.
And I would say it's not, while the contracted childcare slots are directed at infants and under the age of 1, these home visiting slots are not necessarily directed at newborns. So just noting that it isn't necessarily directed at infants, newborns.
Yes, but I'm very excited we're getting them when they're newborn, so that way we can work with the families for longer and support them in their kind of crisis situations.
Yeah.
And Allison, the legislation does specify that the department uses the newly developed contracted rates in the implementation of this. We've wondered about what you just said, kind of an enhanced rate, or like, what does that look like to work with families that are experiencing fentanyl that may be different than other families that you work with. So we have started to wonder about that, but the legislation as is currently written is, directs the department to use the newly developed contracted right in how we do this.
Laura, and just the team, as we work on kind of braiding these things together that are in the child welfare space and in the prevention space, I wonder if we can have additional training for our teams or discussion around how that works. I mean, traditionally, home visiting teams aren't involved in FTDM meetings. We are not involved in safety planning meetings. To be honest, we don't really want to be right now without a training or discussion about what that means for us and for our agencies. And so I see these things coming together. I'm very excited about them coming together, but I would love for us to have some more, I guess, direction on what that looks like.
This is Erica. I would answer, this shouldn't be different than what you're doing now. So you're not necessarily becoming part of their child welfare case. In fact, you wouldn't necessarily be part of that. Lori, what would you add?
Yeah, no, I would underscore that. I think I'm just looking at the law and I don't see anything significantly different about what your role would be. It's more the guaranteed slot funding, and then the department shall provide training specific to substance use disorders for the home visiting providers, which I think that that information would, I would imagine, be linked to what the department and Department of Health and Poison Control Center, et cetera, are coming up with in terms of the risks, et cetera, associated with high opioids. But yeah, I don't see anything in the law saying that the home visitor is going into FTDMs or anything. Still a voluntary service. We were a little concerned, I will just throw in, about confidentiality and HIPAA violations. If it was, okay, hey, home visiting person, you are getting a family who's got this history of substance use disorder and has had whatever. So I think the department is going to have to be mindful, and I understand they will be, of that type of confidentiality. But in terms of changing the role of the home visitor, that was not talked about. That's not in the law. I don't think that was anticipated.
Yeah, and I would just say, Lori and Erica, yes, and because we know that most of the referrals will be coming from families with open cases, and it'll be a lot of work on our behalf to make sure that we have clear understanding with local caseworkers and things like that who are making referrals of what the role of the home visitor is, if it differs from some of the other service providers that they typically interface with. So we've already started to think about that and what kind of pathways may or may not need to be different, given that the structure is a little different than many of the other kinds of referrals that caseworkers are making. So Alicia, thank you for bringing up the point. I hear you, and I agree with what Lori and Erica said, and know that there's some complications there too. So I think Nellie put the order for who's going to go. So I'm going to just say whoever was first on that list. Go for it.
It's me. I was just thinking about just kind of reflecting a little bit about the TANF experience and wanting to be able to use some of those learnings in this environment. And I think some of what we learned is that the nuance and really understanding the criteria developed, the referral relationship, and the acuity of clients that I think should also be considered around impact on caseload is important. So just wanting to raise that this feels like it's a really important initiative, as well as it's going to be really critical that we relook at some of our initial thinking as we progress and evolve. And I think really listening to the programs too around what it means for their manageable workload.
And I think, Liv, that's in part why the strategy of having the contracted slots, because again, the programs will be compensated whether they're serving the full amount of contracted families or not, right? So you'll be compensated. So if you are contracted for 20 on that first day, you're compensated for the 20. And I should have noted, this is built off strategies that have been used in other parts of the child welfare system in the family time space, for example. You're essentially buying supply. So in family time, they buy supplies so that we can have on-demand family time visits. So this strategy was built on that experience.
So I think I'm next. I wanted to build on what Liv said specifically. I had the same thought about TANF. So we have TANF slots. And the referral pathways in TANF are still not worked out 8 years later, 9 years later. They're still very rough. I haven't received a referral from our TANF CSO in about 8 months. So we have to do all the recruitment for TANF, and it's much, much harder to recruit TANF families because of the acuity than it is for us to, and I think you can go, so for example, we're going to a community meeting this weekend and we're going to be asking families if they're receiving TANF because we can get them into services right away. And I think you can ask if they're on TANF. I'm not going to ask if they're involved with CPS. You know what I'm saying? Like that's a bridge too far. So we need to think about referral pathways. I also think a good model for referral pathways would be the early learning liaisons that some child welfare programs have, because I think it's been really nice for us in Yakima. Cindy Taylor, she just sends a referral over, and it's really helpful. Like we actually don't have any direct contact with CPS. She sends the referral directly to us, and it kind of keeps that barrier of voluntary versus like sort of getting sucked into the CPS case. So I just wanted to share that as a thought. I just really worry about the referral pathways. I think that's going to be huge. And we, I'll just share really quickly, like I'm trying to get my new program coordinator onto EJAS for the referral pathways for the CSO. And 2 months in and she's still not on EJAS. You know what I'm saying? So it's like things like that like are huge barriers to referral pathways. And I wouldn't want to see that happen in this situation. So I think that those are things to think about. I think the other thought that I had, I think the biggest, like my first gut reaction was around enrollment versus dosage. So I don't know. I mean, I think my organization would have to think about it. I suspect Yakima probably has a high child welfare involvement community. So I suspect that my program would consider applying for those slots. The tricky piece that I would say is that for those of you who know the essential requirements for the parents as teachers model specifically, it's a very slippery slope on dosage very fast, especially for smaller programs. It's easier for my program because if we don't meet the dosage requirements for our model, and when I say dosage, I mean number of visits, which is 2 per month, and you have to meet at least 75% of those visits. So if it's a whole year, that's 24, you have to have at least 18 visits. Per our model. This is our model. And for a program like mine that has 240 slots right now, if we have, like, I think last year we have 40 families that didn't meet that. And we still met that essential requirement because the percentages work in our favor. But you get into some of the smaller PAT programs, like, for example, Okanagan, they missed it by 1 family. And then that put them out of compliance, out of model compliance. And so I think you really have to consider what programs are going to be applying for this, because this is such a high acuity area, group. And it's very hard to get families who are actively using or have a history of use to do regular visits. It's already hard in TANF. So you have to think about, like, I don't want to lose our model fidelity, because if I lose our model fidelity, we lose not just our model fidelity, we lose our blue ribbon status, our quality standard status. So I got to be really frank. Like, I think we would be a program that would be one of the more ideal ones to maybe apply. I don't know that I want to put our model fidelity at risk. because of the dosage issue on this in a situation like this. I think you also have to think about enrollments, like what's that going to look like in contracts. So this is kind of more to like Renee and Laura, like it's already hard to get enrollment in TANF. I think it would be even harder to get enrollment into these. So I think you have to really think about the model. Like I think you have to think about dosage for the models. I think you have to think about enrollment in the contract and what that would look like. And I think you have to be aware that you may not have that many programs excited to potentially apply for this because of the fear that it will harm the other work they're doing.
So that's unfortunate. Yeah, families could really benefit from home visiting, but I would ask to take a look at the combined in-home services space. When I look at combined in-home services, I think a lot of those services are very similar to home visiting. And a lot of families that are in family assessment and response and family voluntary services, I would imagine, are not that different from the families that you already are serving. So I think there's a lot to learn before there are a lot of presumptions made here. And I would encourage you to look into that because there's a lot of preventive work that's done. I think there's a lot of assumptions made in the CPS world, but there's a lot of work that's preventive. And for home visiting not to be a part of this, I think would be a missed opportunity. Another presumption, and I hear a lot, is that you are serving families. There are programs that are serving families that are struggling with substance use disorder now. So, I think that I wouldn't pressure. I think the idea here is that programs should apply if they think it's something that would benefit them. And these are all real concerns. And I think the idea behind the contracted slots is that it not be a financial liability. I can't speak to the blue ribbon piece. I don't have knowledge about that part, but I would encourage you I would encourage more learning about the FAR and family voluntary services aspects, because again, those are very prevention. I mean, a lot of families in FAR are things like they don't have a washing machine, so their kids are going to school with dirty clothes. So those aren't, that's the type of situation. So thank you.
And if you don't mind, I'm sorry, I know there are a bunch of hands up, but on the referral issue, again, I always like to refer to the bill, the law. And it does say that the referral process shall include referrals from departments, child welfare staff, as well as community organizations working with families meeting the criteria. So I would imagine that I would imagine most of the referrals will come from the DCYF person because they will be involved in either FAR, voluntary services, or a CPS investigation, and would be saying, okay, here's an array of services that now we have available to us. Let's get them in here. So it'd be very surprising to me if the referral pathway wasn't primarily through DCYF. But as Erica just mentioned, a number of families are receiving services elsewhere, including through potentially the Office of Public Defense, and others who I think we do want to be able to make some connection. But I guess I hear the issues being raised, and a number of them are new. Like I hadn't heard that folks thought that they might have to be out recruiting for families. That was not something that was contemplated or brought up, because I'm pretty sure legislators thought workers were going to be seeing families. They need more resources in their toolkit, or whatever tools in their toolkit. And this is a great new one that will be available.
Marilyn, please go ahead.
Yeah, hi, this is Marilyn. So, I don't know if, Nurse Family Partnership would be in this funding stream because, we enroll them when they're pregnant, but we definitely are serving women with opioid addiction and in our caseloads. And, currently we have quite a few. And so my input would just be, you know, the things that have been barriers for us is that the nurse has felt very alone in serving these families. CPS has often pulled out, you know, from our perspective, a little bit too soon. Access to care in our community is really difficult, you know, getting the medical pieces involved, medical support that the nurse needs. The amount of case management that it takes, I would reiterate what others have said, is phenomenal. And also it's very rewarding work because, you know, this woman and this family are willing to work with you. And so like one question I have is, if you apply for some slots and the referral doesn't come from CPS, but as you enroll her, you find out she has an opioid addiction. Often we know that in enrollment or after the first visit. Can you move her from a McV slot to a you know, this funding? And you know, that would take care of the voluntary piece as well, because I agree, we've had, you know, mixed results when the client feels like CPS is telling them to do that. But that's just a thought. Could, you know, once you know it, which is usually very soon, could they be put in that slot?
I really appreciate that question. I think I'll need to do a little bit of internal convening to kind of figure out how the nuts and bolts of that are going to work. But I wrote that one down and I commit to following up with you on that because that's a really good question.
Thank you. I think I'm next, and I think so many folks have already said things so much more eloquently than I could. But what I'm hearing, and if I'm thinking to like experience of working with families or the experience that other folks in home-based have shared with me, I'm thinking how like we already serve families who have histories of substance use, and it is so hard, and there is no space carved out to support that. And the systems are so separate. And we already serve families who are referred by CPS, and there's a disconnect there. But what I'm hearing really is this opportunity, because this is a new bill, to like co-create something that works better. And I'm hearing like a lot of like knowledge and experience in the room, right? The prior comments where we have universal kind of experience, right? Of that disconnect of voluntary, but it's voluntary by your CPS caseworker, or you want a referral from TANF, but maybe TANF didn't fully understand what home visiting was, and then you got to implement it, and then it's the new home visitor who has to figure out how to explain this to a family in crisis. Or, but I'm seeing this as like maybe an opportunity for the systems to better learn each other, like learn each other's languages. And I saw that note about like that development of training, and hearing that like CPS is going to develop training for home visiting services. And maybe this is an opportunity for home visiting to also bridge that training divide. And if you think about referral and how that works two ways, right? Because you need a good communication line. Maybe we're thinking about this like really unidirectionally, and maybe we need to take a little more ownership to making this happen in a way that works for home visiting staff, like on the ground. Think about that new home visitor who's been there 6 months. They get their first opioid family and they need to know what to do. It's not on them to figure it out. It's like the structure. Then we have this new chance now to figure that out. So maybe there's a way to take like all the knowledge and experience you're bringing into the room, and also like the folks not here today, and bring that into that referral arc and bring that into the training process, so we create something a little more sustainable, because those links are happening if we set it up or not. But maybe this is a chance to do it in a way that learned. Yeah, that's it. Thank you for listening.
I want to see, I just think there's some really cool opportunity here. So Chloe, I think what you just mentioned, that there's some ways that our systems can kind of be worked together, and it's been kind of a rub to this point, but I too really want to see this somehow work together. And right now we've got a couple cases that we're working with child welfare, and I insisted on that being at the table together before we ever got started, you know, letting them know that it's voluntary. But I also asked that the case remain open. So I still had a social worker. And I had some, they still have home builders involved. And I know that I can take a hit. And I think one of the things that we can do is if slots are being given out, because I would probably be one that would apply. We have a Suboxone clinic. I mean, we're like in the heat of it. But I know that from PAT National that I will take a hit if I don't have longevity with this family. So this case that I have right now, the mom's being given a chance to parent. And so we are there. And I know that it can be short term because they're already looking at, you know, we'll have been with her 3 months, but they're already looking at sending the child back to the father's father's parent. And so I'm like, but if we only have a couple of those slots, maybe on our caseload where we know, you know, this is a reality, but I hate the thought of not giving them home visiting. And so that's the thing we've been working with our Lewis County office, just it's so crucial. So I'm having to balance what our program wants us and, you know, says we will do, but also having worked with families from child welfare forever, it was like, oh my goodness, this is the best thing we could do, is to be in home. So there are some things that really need to be looked at, just program wide. And I was going to throw out Trissa, what I am doing right now, and we don't have McVie funding, but I'm wanting those families. We've worked with Work First families forever. And so I went to the CSO, and our local office now is having me set up, like the old days, a contract. So we've got all of our background checks now in DSHS, and they're having us go down being a private contractor so that EJAS can be accessed, because I have nothing. So that might be something to really go down that route, I guess, as far as the referrals. We'll see I'll let you know how I fare. Hopefully I've been waiting a year, so hopefully it'll get better that way. So anyway, I just want us to look at this as a huge opportunity and somehow work with our program models to make it doable for us and whatever. So anyway, thank you. Gretchen?
I was afraid you're going to call me. All of a sudden, I forgot my two points I wanted to make. I guess for one thing, I was thinking about what Marilyn was saying, and I mean, I think this would go across the board for all models. That, you know, sometimes these things come up at any point in that service delivery time, so it doesn't. You know, we get many referrals where the mom is actively using. You know, I realize that maybe wouldn't necessarily meet the CPS side, but it maybe the community service side or community partner side. So I think that that's, you know, important. Like, I mean, maybe having some flexibility to some extent. I know with TANF, that's an option, like with getting reverse referrals. So I think that there's a lot of value in adding that in, just because. And the other side is sometimes you just don't know. You don't know for a year until you've been seeing them a year, and all of a sudden it comes up. So just that reality, that it requires some flexibility. And then I just forgot my other point again. Oh, sorry. Going back to what Erica was saying, when we were talking about contracted slots. And I think that that's really valuable. But I also want to stress, like, the importance of, like, there's a need. There's a big need in our state, in our communities. And so it would be great if it was built in somehow that a site can't not, maybe they're getting funded for 20 slots, but they're only going like, hey, this takes a lot of time, so we're only going to, like, fill to 10 or 15, but take that whole funding. Like, I think that it's important that the number of families be served that the funding is going to. And I realize it takes more time. I mean, we at our site, we are doing the FTDMs already. We have been for a long time. It does take more time, but we just figure it out. We figure it out because, I mean, maybe another family over here isn't as high acuity. So it's just it's a balance. But I think that, you know, all of the funding that comes to home visiting is so valuable and so important. And we have an obligation to make sure that we serve as many families as possible with that funding. That's just my opinion. Thanks.
Thank you, Gretchen. I just wanted to say, because I was listening to all of you, and there's a lot to digest of what we're speaking and what we're saying. And I think sometimes because the rush of the situation takes us to make decisions that will not be beneficial. So I was just wondering, how can we support this process for you, DCYF? I mean, how do we design it? Because I know I see a lot of ideas, concerns, suggestions, and I would not like to miss the opportunity to have really involvement of this group. And also, how are we involving the other partners that are not sitting down here, And I don't mean just during this meeting. I mean, how are we going to design that referral process? How are we going to do it? What are we going to put in the contract? I think not just this meeting will be enough. And I feel that sometimes we're in a rush because we need to go to the next thing. And I was just wondering, how can we support this process? How we can be involved in this process and not wait until the next HVAC meeting to design something with you all that, that I think will need our input. And the input, and I will say our, meaning the community that we serve. I don't mean me as a Best Start for Kids. I mean, the partners that you all have and the partnership that you have to make it work so that it works for you. Just wanted to mention that.
Just to connect it in some ways to what Adrian was saying, and a little separate from things we've been talking about, I just think it's important. I heard Lori, I think it was either Lori or Erica, you mentioned mandatory home visiting or some level of a mandate. Was that not true? So this is not going to be mandatory. Good. So there's no required because of CPS. Okay, then I misheard that. Okay, that was what I was commenting on, is just that creates a lot of challenges for home visiting programs who have been fighting that stigma with community members for a really, really long time. So even for these families, it will be voluntary, even though the referral may be through CPS, potentially, or connected to CPS. Anyway, obviously this is something that needs to get figured out. My key point is just, this is going to be something that's very helpful to have community and partner input on, just because often the rumors precede the reality when it comes to mandating things like services and home visiting, and can create some complexity for home visiting programs that have tried really hard to build trusting relationships in certain communities. So I'm glad to hear that I misheard that, and apologies then.
No, thank you for clarifying. I'm sorry if I said anything that was leading you to think that. No, I know Erica, and talking with a lot of legislators about home visiting over the years, and voluntary. It's like that hopefully is in the minds of policymakers, but yeah, that is so critical. Thanks for clarifying.
Erica and Stephanie, if you don't mind kind of wrapping this up for us, and then we can transition, that'd be great.
Yeah, and thank you for the robust conversation around this. I just want to say, really appreciate the opportunity to learn from everyone. I think it's been really beneficial to hear what's worked well, what hasn't worked well, and just so excited about, these new opportunities. And I think that we have a really good opportunity to work well together. And implementation. So Eric, anything to add?
No, thank you. And I neglected to say earlier that I hear all of the implementation. I realized that we had the privilege of working at a very high level and the challenges in the implementation. So I did want to note that the hearing and the opportunities to make changes next January. So this is from my perspective and Sir Early's perspective, not set in stone. And we worked really closely with DCYF and Lori, of course, in the crafting of this language. So I think I can speak with Steph on behalf of Steph, saying that we stand at the ready to, we of course want to make it foremost workable for families and workable for programs and make sure that you're funded. The idea behind the rates was that, and the contracted was that the programs would be resourced. So hearing you about the acuity piece and such, and definitely want to be involved in the referral discussions as well. So thank you very much.
So thank you so much, Erica. Thank you, Steph, and thank you, Lori, for being with us. And thank you all. This was a really good, rich, involved conversation. And if you haven't had a chance to take a look at the chat, I would encourage you to do that. I think Laura did an amazing job of kind of capturing the key threads. Also, want to reiterate something Laura mentioned at the beginning. We are in the planning process. Our intent is to engage all of you and engage other stakeholders in this process. So we are looking at it, mapping it, and we hear that loud and clear that you're interested in being involved, and we're committed to making that happen, just have not built the structure for that yet. So more to come on this discussion. This is not going to be the only time. And then want to transition us to the next part of our agenda, and we have Ashley Pena and Sarah Pine joining us, and I'll give them an opportunity to introduce themselves here in a little bit. But what they're going to be presenting on, we thought would align really well with the conversation that we have just had. And so we're looking forward to hearing from them. We're looking forward to engaging in a conversation with them, and hopefully you'll see the connection and alignment with what we've just discussed. So with that, I'm going to turn this over to Ashley and Sarah, and thank you so much for taking the time to be with us this morning.
Hi, thank you so much for having us. I really appreciate y'all taking the lead on flipping through our slides as well. It gives me an opportunity to read my notes and be thorough. Good afternoon. We are going to present on pregnant and parenting services and the Parent-Child Assistance Program, also known as PCAP, and we're from the Division of Behavioral Health and Recovery through Healthcare Authority. Next slide, please. My name is Sarah Pine. I am a behavioral health program manager for pregnant parenting women's programs and special projects, and I'm going to discuss PCAP with you today. Next slide, please. PCAP is a 3-year intensive case management program that is currently offered within 15 contractors statewide. In total, PCAP is serving 20 counties and is contracted to serve about 1,500 clients slots currently. The program is funded with both Medicaid and state dollars. And also DBHR has service level agreements with both ESA and DCYF to support PCAP services dedicated to TANF or Work First enrolled clients, and also DCYF clients as well. Women are eligible for the program if they meet the following criteria. 1, they are pregnant or postpartum up to 24 months. Priority is given to pregnant and postpartum up to 12 months. 2, self-reported substance use during current or recent pregnancy. And 3, have not yet successfully accessed community resources for STD treatment and long-term recovery. Additionally, those with a child who have a confirmed FASD diagnosis may be enrolled in the program regardless of their pregnancy status if they are still able to become pregnant. And next slide, please. This slide here shows you the array of different services that a PCAP case manager may connect a client to. They offer clients referral, support, and advocacy for STD treatment and continuing care. PCAP case managers work directly with clients to support their individual needs, which can include linkages to healthcare and appropriate therapeutic interventions for children. Next slide, please. The University of Washington's ADAI PCAP training and evaluation was formerly known as FADU, the Fetal Alcohol Drug Unit. We also contract with them to provide PCAP sites quality assurance and implementation fidelity of the PCAP model, as well as staff training and program data collection and evaluation. The data collection and evaluation are provided to DBHR in both monthly and annual reports to DBHR. The monthly reports show total monthly client counts statewide, and the annual report provides a statewide assessment of the program and an in-depth look at the demographics of PCAP clients. The demographic report contains data in many areas, some being client background, substance of choice, domestic violence experience, number of births, etc. Next slide, please. This slide here, I want you to check out the green parts. That's what we're referring to here. So DCYF provides funding to support PCAP in a service level agreement. This support goes to 4 PCAP sites indicated in the green on this map. We have King, Clallam, Jefferson, which is one location, Yakima, and Spokane. Currently, these sites dedicate 14 client slots to DCYF involved clients. The current service level agreement language states that a substance exposed newborn diagnosis is required. Next slide, please. So sorry, I see that my slides are a little out of alignment. I will get back to the DCYF stuff in the next slide, but first I will address that funding was assigned for fiscal years 2024 and 2025 to increase rates for PCAP providers by 15%, which was effective January 1st, 2024. And next slide, please. Oh, sorry. Okay. In recent legislation, funding was provided to expand PCAP client slots with the within the DCYF service level agreement in mind. DCYF initiated a decision package for this expansion, which resulted in an expansion of 56 client slots by the end of fiscal year 2025. Currently, DCYF and DBHR are partnering to update the service level agreement to reflect that the DCYF client slots must only have an open case, removing the limitation of receiving a substance exposed newborn diagnosis. Once this updated service level agreement is executed, the 56 client slots can be assigned to the 4 participating PCAP sites in amendments. I don't know if we need to pause for questions on PCAP or wait till the very end after Ashley's done. Any recommendation here? Okay, I'm going to move it over to Ashley and we'll wait for questions at the end.
Yep, that sounds good, Sarah. Sorry, I couldn't find the mute button.
It's okay. Thank you.
Hello, everyone. Thank you for having Sarah and I. My name is Ashley Pena, and my role at HCA and DBHR is Pregnant and Parenting Family Substance Use Disorder Policy Administrator. Today, I'm going to talk about Pregnant and Parenting Women's Services. It is a part of the work that I oversee in partnership with Sarah. She also supports that work as well. I'm going to go over what PPW is, some challenges faced by PPW providers currently, and some solutions. And then I'm also going to discuss current PPW expansion efforts. And at the end, I'm happy to give a brief update on the work being done at HCA that is in alignment with the directive set forth by Senate Bill 6109. I only have a brief update, and I'm happy to follow up with anything after I do my presentation if there's more questions on 6109. Okay, I'm gonna go off camera because it helps me focus, and so you don't have to see me reading. All right. So, pregnant and parenting women's services are designed to meet the needs of pregnant and parenting women seeking these services. PPW, pregnant parenting women, are a priority population for the federal substance use, it used to be abuse, but it's use block grant funding. PPW services include inpatient and outpatient SUD treatment. Residential substance use disorder treatment is available for women and their children under the age of 6 for up to 6 months. Structured clinical services are provided in a planned regime of patient care in a 24-hour live-in setting. Next slide, please. So there are currently 6 PPW substance use disorder inpatient programs in Washington State. They are located in Snoqualmie, Yakima, Thurston, and Clark County. Total combined client capacity is 109 client slots, with 78 slots allocated for children entering treatment with their parents. Snoqualmie Evergreen Recovery Center's new site offers the state's first pediatric transitional care facility. Pediatric transitional cares for newborns with neonatal absence syndrome and/or neonatal opiate withdrawal syndrome to receive on-site pediatric transitional care services in the residential treatment facility with their mother present, as opposed to receiving care in the hospital, potentially separated from their mother. Next slide, please. So on this slide, I'm going to provide a few challenges and some working solutions on behalf of my partnership with the PPW providers, as well as HCA's partnership with PPW providers. So first, reimbursement rate. So there's no set rate for long-term residential services. Each PPW provider contracts with MCOs to determine rates per their program. In addition, Medicaid does not allow for room and board to be paid using Medicaid dollars. Room and board is paid for by general, federal, and state funds. However, the PPW room and board rate did increase to $14.28 as of 2024, whereas prior it was $11.63. Providers report this rate is still rather low, as we can see. However, rate increase is still an ongoing legislative effort. Next, I'm going to cover PPW program requirements. So it's a licensing requirement for residential treatment providers accepting children into treatment with their parent to provide on-site childcare services. Childcare is not covered by the reimbursement rate. PPW providers pay the cost of childcare services through creative means that are individual to each provider. However, HCA is working on clarifying billable mental health services provided on behalf of children accompanying their caregivers at a PPW program. HCA anticipates sharing new guidance and seeking input from PPW providers in early summer 2024. This work will not change the existing processes for accessing block grant dollars for therapeutic interventions for children that are not covered by Medicaid. Providers can continue to work with MCOs and BHASOs regarding how to access those resources. And last, funding parameters. So the funding allocated to increase the number of beds for pregnant and parenting women programs have restrictions and cannot be used to purchase or improve land, construct, or permanently improve a building or facility. This is a challenge for PPW providers as current sites cannot always accommodate a bed increase, even when a provider is interested in expanding services. In partnership with PPW providers, I do let them know about funding opportunities for capital projects, such as the recent conference funding, which was about $7 million, and these grants were specifically for capital projects such as constructing or building of a new site. Next slide, please. And with that said, there is currently underway a PPW expansion effort as directed and outlined in House Bill 5127. The directive is to increase the number of treatment beds in 2025 by 16, with the assumption of 32 additional beds phased in through 2027. The total funding source amount is $1,425,000, and that is for the increase of 16 beds in 2025. And I oversee that work. So on the next slide, I will share how that process is currently unfolding. So this slide outlines the description of the notification type, audience, and timeline to expand PPW treatment beds in 2025. A letter of interest was submitted to current PPW providers and substance use disorder residential treatment providers, including tribal providers. In addition, I submitted a Dear Tribal letter, a Dear Tribal Leader letter to inform tribes of the funding opportunity. The letter of interest was released on April 8th, and submissions are due by requesters on April 25th. Next slide, please. So that concludes Sarah and I's portion on PCAP and PPW. A brief update on 6109. So 6109 directed HCA to increase behavioral health and support services for children and youth with prenatal substance exposure. Currently, the status on that is HCA is in the process of hiring an FTE to focus on and lift this work. It is currently posted, so if you know a good batch, it's posted, and we are looking. HCA is working to get the first service contract in place. More details on that to come once it's finalized. Additionally, HCA is working to get a procurement announced, hopefully before the end of the month, mid-May, and this is for support services tied to this portion of the bill. And that's it for me. Happy to answer any questions.
Looks like Nina has her hand raised.
Thanks. I just wanted to quickly ask, and I apologize if I might have missed these details in your presentation, but do these programs intersect with treatment courts in our state? And then also, I'm thinking about that, but also wondering if your work is intersecting with some of the expansion around therapeutic family services as well in the early learning sector.
Yeah, I would have to follow up with you and spend some time thinking about that and connecting with the PPW program. I do know that they work directly with child welfare involved caregivers in family court settings and works specifically with any reunification process. So that I do know. In regards to family-centered services or therapeutic interventions for children, yes, we are working right now to make sure that there is some clarity around what services they can access and bill for, as well as any support we can provide in establishing clarity and or resources for current PPW providers around those services.
Ashley, there's a question in the chat about wanting to know referral pathways.
Yeah, tell me more about that.
We are primarily in King County, but also have families that are in Pierce and Snohomish counties as well, and also working with pregnant and parenting families. And so, just if there are what are the simplest ways to refer families to the program that are local to us? And I'm happy to give you my email if you want to send very specific information.
Yep, That I'm happy to do so. Go ahead and shoot me an email and I will send you a contact information. I do have a provider list that I can send that's just basic information of how to contact those providers. And because there is very few currently in Washington State PPW programs, the ones that I showed on my slide are the only ones available. And so it's just really dependent on availability of beds at that time. I do know that for some programs, the referral process and the wait can be a little bit long. Again, like I said, it's dependent upon availability at the time.
Thank you.
Of course.
I'll shoot you an email.
Okay, sounds great. And I'll add our contact information into the chat as well for easy access, and the slides will be sent out with meeting notes later.
Thank you for that, Ashley. Any other questions? Oh, Laura, go ahead, please.
Yeah, I was just curious, Ashley, and Sarah, and this may be on a later conversation, just thinking about the conversation you just heard about 6109 and opportunities in home visiting, if there's anything that, you know, from your perspective and working with this contractors or working with this population, if there's anything we should be thinking about or thoughts that you had based on this conversation. And again, you can think about that and follow up later, but I was just curious about your sharing your expertise, anything you thought of as you were hearing our conversation earlier.
What immediately comes to mind for me is just being aware that what PPW means and what the program offers. And so I'm happy to also include in an email a fact sheet that goes over the sort of what a PPW program and what PPW services offer, just for when folks are connecting and doing home visiting and there is a need for residential treatment services or outpatient services, that information is well known and connecting to those programs is also available. So I will send out contact referral pathway list and then also PPW fact sheet if that's helpful. I'm not sure if Sarah's on anymore, but that's it for me.
Oh, I'm here. I'm just trying to understand. I think my, to be very frank, I'm relying on my internal partners who have worked on 6109 to loop me in where they see a connecting piece to the work that I do and oversee, which does include PCAP. And if there is a correlation there, I will definitely connect you guys on the updates on that as we move forward.
I want to just highlight too with 6109, one of the things that I do see being important is the need for family-centered services, as well as an increase in residential treatment services for families. And so I just wanted, I guess what I'm trying to get at is highlighting the importance of just any opportunity that there is to bring awareness of what PPW programs can offer. I'm happy to present and or be a part of any of those conversations.
Thank you for that, Ashley.
I
Thank you.
don't just
ahead.
quickly, I don't know if there's time, but Ashley, I also, and it may not be appropriate, but I wonder if you might also mention the Grays Harbor effort.
Yeah, no worries. I can also send some follow-up information on that. So in partnership with the Department of Children, Youth and Families, I have developed a model, and the model is called the Family Preservation Model. The model can be implemented across the continuum of care for the purpose of a residential treatment facility that hopefully will be up and running in Grace Harbor County. Right now, there is an RFP process underway to contract with a provider. The residential treatment program is a 16-bed facility, and it will serve pregnant and parenting individuals, inclusive of fathers, for children and their parents, the children up to age 12. And the family preservation model will be implemented into that program. So that will be, hopefully, fingers crossed, another service available to families. And that will support some of the work that is being implemented as a result of 6109.
So thank you again so much, Sarah and Ashley. And Ashley, we would love any information about the Grace Harbor pilot or process. So any information you could share with us would be great, and we'll get that distributed out to our HVAC members as well.
Awesome. Thanks so much.
Really appreciate your time and you being with us. So we are scheduled for a break right now, but before we do that, I talked a little bit about at the beginning about our June date for an in-person meeting in Spokane, and it happening right after Juneteenth, and we're not wanting people to necessarily have to travel on a holiday if that is a holiday within the work that you do. So we want to do a poll to see if people are still okay with doing that, or would prefer a different date. So as we're getting ready for a break, which we're scheduled to start here in a minute until 12:05, if you could take a moment, either as you're headed out to your break would be ideal, as you're coming back from your break, just to vote so that we have a better understanding of when that meeting will happen, and it will help us also plan. So if we could have, and just HVAC members do the vote would be great. Thanks for clarifying that, Nina. So again, please feel free to vote right before you take a break, and then we'll get back together at 12:05. So get a moment to stretch, do what you need to do, and we'll connect and do our, we'll be back at 12:05. Thank you.
I have a question, but Laura just went off. But, oh, now she's coming back on. I am just wondering, is there a option for virtually attending this, or is it you have to travel to Spokane? Because that's going to influence my decision.
So it's a hybrid meeting. We always offer a hybrid option because we know things happen and travel may not be possible. So it'll be a hybrid meeting, but it's our in-person option, our second one that we typically do for our HVAC here. And thanks for asking that, Allison. I should have mentioned that as part of kind of the voting. So appreciate that.
The request from our home visiting, thank you for recording again, our home visiting advisory committee co-lead to help us plan for this, to have some open space, given the conversation we had in our last meeting and sharing about some of the roadblocks that we've encountered, that we really have an open dialogue time. But I do want to do a little bit of kind of background. A few of you may not have been at that meeting. And I also want to call to your attention that in the email that went out, I think it comes from the community engagement email, there was a letter also attached that went out to LIAs, our local implementation agencies, now a couple weeks ago. And that's a good reference point for you as well. We'll get there a little bit later, but just want to also call out that that was shared with you all so you could kind of get a little bit more detailed of where we're at and things like that. So really the goal that DCYF has broadly is to support client services contracts to be able to utilize a similar methodology across the agency for how rates are set and to be able to support increases over time. So really it's the intent is that we use a consistent, real economic driven approach for setting rates across all of our program areas that allow us as an agency to ask for ongoing increases as needed as years go on, and we know that the cost of services change and program and community changes over time. So I'm not going to read all the slides, but just you all have seen some of these slides before. So just wanted to go back to a little bit of the Y rates. And this for us moves, us from a budget-based approach to a rate-based approach and home visiting. For some other parts of the agency, you can go ahead. You're good. Go to the next slide. For others in the agency, they're using a different rate approach. I did want to bring this back up because I was looking at it again this last week. The Home Visiting Advisory Committee recommendations regarding true cost of services had 3 elements, 3 primary recommendations with some key strategies under each of them. And while the Department of Children, Youth, and Families using this standardized rate-based approach has not hit every one of these on the head, I do think that there have some of the strategies that we're using in this approach are moving these strategies as well. And I also wanted to note that under the workforce recommendation, there's a wages specific recommendation as well, that the model that DCYF uses using the SOC code or a minimum threshold supports that as well. So just a couple that I'd point to is that it was asked that stakeholders be involved in a cost study. While we're not doing the cost study in that way, we're setting rates. We have been attempting to, we think, bring in stakeholders along the way and have meetings and gather information and feedback. While there's been a bit of a pause as we've kind of recalibrated a few things given the roadblocks that we've experienced, particularly with McPhee, we are really doing our best to engage stakeholders, and you all are included in that as well. We're really also looking at some of the infrastructure needs as well as the staffing needs, as we know those are some of the key drivers for home visiting, and those are listed here in the strategy. So I just wanted to kind of point back to that and again say, while not all of the strategies are being met exactly, I do think some of the approaches and methodologies that we are implementing are aiming towards those strategies and recommendations that were in this as well. And also really that first strategy or the first recommendation that says a strategy that builds in regular adjustments for all programs to ensure equity and sustainability. And that's really the basis of the rate approach, is to be able to ask for increases as costs change over time to support sustainability and growth of our programs. So noting that. All right, why don't we go to the next slide? Okay. Again, these are slides that you all have seen probably multiple times, maybe you less than some of our LAAs, but this is just kind of what goes into a rate. What is the service need? So for us, home visiting, what are the home visiting model standards? What are our contract requirements? And then what are the costs associated with those? And then getting to the payment methodology. So that's kind of the steps in there, and we're in this kind of cost identified and then the payments defined as well. You can go to the next slide, please. Again, going back into that, how are they built? So really looking at personnel costs, service delivery and workload, quality and training costs, overhead and operations. We've primarily looked at 3, while DCYF has a model for overhead and operations costs that's a standard model that we used for the rates. We have not really done the stakeholdering around that piece yet of the model, so that's still yet to come, and I'm looking to Renee to validate that that's correct. Am I saying that right? I think we haven't totally done the operations and overhead piece yet, and I think that's going to be one of the next areas when we get the rate to look at that as well. Okay, let's see here. I'm trying to think if there's anything else key on this slide. But we've done some of the work on service delivery and workload validation for several of our models. We've identified training costs and personnel, things like that, and still have that last piece to do as well. Okay, go to the next slide. And Renee and Nellie, please come off mute if I'm missing stuff. This is, again, we have heard from you all, from our LAAs, as well as it is centered in our work at DCOAF, is how are we thinking about any of the policy work as it relates to advancing racial equity. These are some of the key questions that we've asked sort of at the beginning of the process and asking our partners to help us check in with along the way. And do know that it's a little hard in some ways to check in on this now because we don't actually have a rate yet to know how it's going to impact different organizations. But noting that these are some of the questions that were defined early on the process and asking for, we're asking ourselves and asking you all to help us think through as well. I think we can go to the next slide because we kind of are getting closer to where are we at now and what's implementation looking like. So just, this is something I think that's in our head, but we haven't always stated outright. And it also kind of goes back to the Home Visiting Advisory Committee recommendations is, you know, these are some base assumptions as we move into this next stage of getting to implementation is we do want to minimize slot reductions as a balance with increased funding, as was shared in the letter as well. We have funding to do some increases, but probably not fully, and we know that. And so we want to really think about what is that going to look like for how we advance some of the rate work and not completely reduce slots. So it's that balance for us. And also we do really want to maintain quality and impact as we implement rates. So that's part of how we've built this work, why we ask you about model and service delivery, why we're asking you about training expectations is because we do want to really move forward with making sure we are paying sufficiently for quality and impact. Well, you can go to the next slide because I think what we were kind of hoping to do was just give you a little bit of the insight into how we're thinking about this right now and where we're pondering where to go next. And this again is in any of our policy making work, there are tensions, right? When we're doing statewide work, that is just the way it is. Is it quantity? Is it quality? Like, what are we thinking about here? And how do we do our best, our very best, to address both the tensions and listen to partners and make good policy decisions? So a couple of things I just wanted to highlight. Again, these are things that we're thinking about all the time, but they're not always stated. So I wanted to kind of invite you into some of these thought processes and tension and get your perspectives on them here shortly. Is that we know that our current approach has really been organizations implementing or submitting budgets and us funding those, though not increasing sufficiently over time. And that's a more individualized approach. And with rates, there may not be full standardization, but it's moving towards standardization. So where across the program model, the payments will really be same or similar as well. So that there's a tension there. Like, what does that mean to move from fully individualization to standardization? And how are we thinking about that and the impacts of this work? The increased cost tension, and these are just a few, there are others, I should have said that as well, is that we know that funding will support incremental increases, but it will probably not pay fully for the cost as has been over time. We've done 2 to 3% increases, 5%, 7%, you know, as we've had funding to be able to do that. And we know that sometimes we've done some slight reduction in slots, but there's this tension around, like, if we're not paying fully, you know, how do we keep slots and capacity available in community for families? And our partners in communities really have kind of navigated that and figured out how to make it work in community as those tensions have been there. I think the other piece is that we know is a tension and we're not totally sure how it's going to play out is that case rate payment for family serves, at least to in part, may result in different capacity than the current capacity based on cost reimbursement for slots. So these are tensions that are kind of in the system, and we know, you know, result in us thinking about, okay, what does this mean? How can we make the best decision here to support all of our programs and the families and communities, knowing they don't all look the same as well. Again, as noted above, these are similar across DCOAF program areas, not just home visiting. These are all the kinds of tensions that that exist in statewide policymaking and the work that we do. We have a couple visualizations of that and how we've kind of thought about it over time as well coming next. But I just want to pause and see if any of my other DCRF colleagues want to jump in and share anything at this point before I do that. All right, you can go ahead to the next slide. The data here is a little old, so I'm just going to say that. But the reason I wanted to, Trista, I'll respond to your question in just a minute. So this data here is from 2021. It's older, so I want to say that. And the slide next is a little bit more recent, but still not totally accurate. And it takes a minute to kind of get your minds around it. But using all the data that we have in the PCQs, the pre-contract questionnaires, for those of you that are working a local implementation agency, we plotted out like what's the variation in salary across programs that are kind of similar. Not totally. So you'll see that nurse family partnership and child parent psychotherapy are not on here. We mapped those separately because the variation was really huge when we put them all together. So again, what you see here is that even in Parents as Teachers, Family Spirit, our doula, and Early Head Start program, looking at salaries and benefits, there's quite a range, and that some of our assumptions don't always hold true. So King County's in red, black and dots are Pierce and Snohomish, and then the lighter blue are other parts across the state. So why it was important to look at this is because we know over time we've consistently gotten feedback that home visitor salaries are too low. They need to be higher, and we know that. So as we were thinking about at that time an increase that we were able to give to programs, I want to say it was like 3 to 5%, something like that. We were looking at what's the distribution of wages, salary benefits across programs. So this is called a scatter plot, and we'll do something similar for the rates. So as we think about how far our current programs are with our cost per slot and what we think it will be when we set the rate, we'll do something similar. And what we know is that, our goal is to reduce variation in this so that we're paying more similarly across programs, and that we at least, raise the floor. It helps us to really kind of consider what is the current picture. And so we'll be doing that, and we'll talk a little bit more about that in a little bit. But I just wanted to show you that, if we were to say our ideal salary and benefit for a home visitor across the state was $70,000 as an example in this slide, we know that some programs, that means that they're $30,000 below. We also know that there's one program that's paying $15,000 above that. So what's the implication of that for the rate? And it's the same thing with our rate approach. Like, this is just an illustration from a prior work that we did to try to figure out how could we support LAAs to pay a higher wage, knowing that there's this variation to, kind of mitigate the difference across programs, because that's, again, something we've heard over time as well. You can go to the next slide because there's one more illustration. And this was something that we did in SFY 22-23 when we did an increase. Again, kind of a different way to look at it, but it was showing the ranges of funding across program. And I do think we might have presented this to Home Visiting Advisory Committee or some version thereof a couple of years ago when we were considering this funding and how we were going to distribute it. And again, the goal we were thinking about was to increase the floor. So where's that minimum, increase that, and how do we reduce variation? And so we looked at some different ways to disseminate funds to programs to not exacerbate that variation, but to bring up folks and to continue to support some increases for folks that were even at the top. And the reason that we shared this with, we do this and we're thinking about this right now, it's a similar approach that we have for rates. So there's trade-offs, right? There's policy trade-offs in any of the decisions that we're making along the way. And we're hoping for them to be informed. And so again, kind of a view in, that's part of the principles that we're thinking about, or that we're trying to ask for data or support to visualize what are the implications of any direction that we go at this point, so that we can make informed decisions. And so I wanted to share with you, again, we'll probably be doing something similar as we get the rates a little closer to final with where are programs at now and where does this take them, and are we doing that kind of thing where we're bringing up the floor, reducing variation, getting closer to programs being able to expect similar payment across area. Okay, so I think there's one or two more slides. that I have. So here's just a little bit of the updates. And I do realize I talk fast. I've gotten that feedback before, so I'm going to try to slow down. I'm sorry about that. That we have worked with our 6 models to develop and gather data and input around model fidelity requirements, the implementation of the contract that DCYF has with our 6 programs, 6 models that are continuing with rates. We have 3 that have been exempted from a rate approach, working to develop shared understanding, which is really critical, both of the model and of the drivers of cost, and then working with the legislature to support funding available to support some of the increases and in the future increases as well as we work towards implementation of rates. We also are getting to work with HRSA, Health Resources Services Administration, who's the federal agency that we work with to implement the MCV program as well, the Maternal Infant Early Childhood Home Visiting Program, because currently under federal rule and expectation is they don't really have a structure to support implementation of rates because they expect states to pay for actual costs. So we're negotiating with them how our rate model can meet that definition for them as well. Okay, next slide is just a brief summary of what was in that letter that I shared with you. We have our state-funded models only. So we have 4 models that will move ahead with rates. That's 9 LAAs. And then we have our MCV and state-funded models that are rate delayed that we're working on interim budget increases for, and then rates exempt models that will also get a budget increase for July 1. And there's 3 models, 4 programs in that group, and I think about 35 in that second group as well. And as I've just shared with you here, we're now working through these policy decisions, holding our assumptions and grappling with the tensions, and through meeting with you all, we are seeking information to better address these tensions, make informed decisions based on the context and reality of what will be a phased approach of implementation and fully funding the rate model as well. I'm going to pause there because our next slide is a discussion, and I know there's a couple questions in chat. Oh, can you get an update? Okay, so first, Trissa, I don't understand the SWAT families served tension. Does this mean across cohort? I think that was the last bullet. Oh, I knew that was going to happen. My headphones were going to die. I got them out just in case. Let me switch my headphones and then I'll come back to your question, Trissa. Just a second. Do anyone else's AirPods last them through a full 4-hour meeting? Because mine never do, and they always seem to die when it's my turn to talk. Sorry about that. Okay, so the rates exempt models, it is in the letter as well. We have 3 of them. It's Early Head Start, home-based, Early Steps for School Success, and Steep Steps for Effective Enjoyable Parenting. They're programs that make up less than, I think, 5% of our overall portfolio, both in slots and funding. And at this point, don't necessarily have a large expansion plan in place. We know Early Head Start's getting funding elsewhere and things like that. So just noting that there was kind of a whole paper process that we went through to exempt those smaller organizations, smaller models that make up a very small percent of the programs. So thanks, Renee. I knew you would have that on hand as well. Let's see. I think I got that, Chloe and Dila. Okay, Erica. Erica got, so someone else is addressing Eric's question. Back to yours, Trissa. I'm sorry, I jumped around there. My chat was moving. Okay, the slot families served tension. Can I kindly ask, I don't know if it's Emily or Soraya that's doing the slides, to flip back to that tension slide so I make sure I'm answering the right thing. And Trissa, I welcome you to come off mute. Our next slide is questions. One more, there we go. Oh, one more. Oh, other way. Back up to the bullets. There we go. This is one I don't think we totally know yet, Trissa, of what the implications might be, but in a scenario when we're paying for a case rate, which is different than our current kind of slot reimbursement rate that we're doing, or not slot reimbursement, cost reimbursement for the slots that exist in communities, there may be, the implication may be ultimately we pay for less families served, or may in fact be that there are more families served. We're not totally sure yet what that's going to look like. And so I think that's part of what we're aware of, is the shift, is attention both in the system and in communities, that we're not sure yet the implementation as well.
One of the things that comes to my mind going to this kind of fits in with this specifically, but just in general, this update. And maybe you'll talk more about kind of HRSA's stance, but we were directed, as in Catholic Charities, was directed by, I don't know, somebody who did an outside audit, that we needed to tie together, and we couldn't do auto allocation anymore. So forever and ever, we've done auto allocation, where, some percentage we would estimate, okay, they're going to be working with, because we have 3 funding sources for our program. We have MCV, we have TANF, we have GFS. And you guys have not been able to raise TANF or GFS really. So a lot of that has, TANF and MCV. So that's gone into GFS, which worked when we were doing auto allocation. But because we've been directed as an agency to tie directly, like, number of hours actually worked in a cohort, as you can imagine, MCV can no longer sustain in any way the workforce that it takes to provide services to those 127 slots. So because you guys have generously, and I'm not complaining, GFS is great, like it's kind of our catch-all, because you guys have like given us slots there. We have, I think we're funded for 78, but we also have additional funds that you've done to back up MCV and GFS. We move literally anything we can. To back up TANF and MCV, we've moved anything we can in GFS. My salary is 100% in GFS. And it's kind of going down that way with all of our leaders as well. So at this point, it can only sustain like the 6 or so FTE for those 127 slots. And the point that I'm trying to get at is that, like, do you even have the capacity to potentially reduce those slots, or in any way, like, kind of strategize with us about how to, like, because we can't just get it in GFS, like, it needs to be in those actual cohorts so that we can sustain those numbers. So is that kind of what you're talking about here in slots family served tension?
Yeah, and the one above it too, Trista.
Okay.
So trying to get the funding sources and the slots right sized and allocated correctly. So their fund source is paying for what's being provided by that fund source.
Yeah, exactly. I mean, I think at this point, slots per GFS is probably very disproportional in what we get paid for slots for MCV would be my, in fact, they're almost exactly the same for us across like the 2 budgets, but one has 127 slots and one has 78 slots. So just, they're very different.
Yep. And we're aware of that. Yep, totally. Yep, tracking that.
And how is
thanks,
HRSA
Trista.
handling that? Like, what's your, can you even reduce slots in MCV? Not that we want to reduce slots. I don't want to reduce slots, but like, if it comes to that, I guess is kind of what I'm asking.
Yeah, I'm actually going to ask Soraya to go back. There's a couple more slides. Yes, that's part of the negotiation, Trissa, with them, is to figure that out. You can go just to I think it's the discussion one was next anyways from where I'm at. And we have had an increase of MCV funds, Trissa, from FFY 22 to 23. Our 24 actually dropped fairly significantly despite the increases due to federal sequestration. I'm not going to go into great details with that. The legislature did direct us to utilize as much of the increase in MCV as we could to support rates increases and not increase slot numbers, but there are some nuances, whether we can do rates, those kinds of things. So we feel like there's some MCV funding available to right size it, but the methodology part is the piece that we have to work through next as well. So I'm gonna I think that was the last slide. I'm gonna, before I do totally open discussion, I think Vicky's still with us, or did she have to hop off? I knew she had to hop off. You're still there. Do you want to offer anything at this point, Vicky, and then maybe Nellie or Renee, if there's anything?
Thanks, Laura. I was just gonna say a word about the question related to the slots and family served tension. I think as we've gone through this, one of the way that comes out is that when we pay based on a budget for slots, and the slots usually are not all filled, we know that that's one way by which we can continue to serve families with the budget available. But slots really are intended to move toward paying for families served. And as we do that, as we increase rates so that we're paying for families served, and that should accompany an increase in rate, we may have to decrease slots. And if that happens, it's going to look like we've decreased capacity, even when we haven't decreased capacity. So that's sort of the tension that refers to. That was the only thing I wanted to clarify. Thanks.
Building on what Vicky said, I was put this in the chat too, but I'm wondering if this is also an opportunity in time to align how caseload is identified with models, because many models actually use child to indicate their caseload rather than family. And so is this a good time to think through that together?
All right, Gretchen and then Dima.
I just want to bring forward I guess the importance again about, I know that there are, when looking at the reimbursement, they're looking at regions, and I just, I guess I don't know, when I just think about equity, I feel like over and over again, our rural communities, our smaller counties that have a harder time filling positions as it is, and often are serving underserved populations, just because of whatever is being looked at. It's a constant battle to get a salary there that is competitive and able to meet what other service providers are paying. So it's just an ongoing battle. And I know I said it in one of the rate setting meetings that I really feel like the equitable way is to look at a salary across the board, across the state, because in our rural communities, over and over again, we can't get services there because we can't find staff to work there because of the pay. So it's an important part, because I mean, they are some of the highest risk families, and they deserve services just like everybody else. Thank you.
And Dila, go ahead if you were next, if your hand's up, if you still had.
Yeah, thank you. I was able to look at the letter that you sent to the LIAs about the process and the timelines for completion of the rate setting. So thank you for that communication. And I'm clear that different parts of the portfolio are moving at different paces. For example, some of the MCB models are not going to have their rate setting completed by the contract deadlines for this year. We were one of the models that is still in the process, and the goal, according to that memo, is for us to complete the rate setting process by this upcoming contract period. And I just wanted to share, I have concerns about how that is going to happen. It is nearly the end of April at this point. We have no information about what salary ranges are used for our home visiting staff, which is about 70% of the cost that we request from the home visiting program. There is no equivalent for our type of worker, our home visitor who's also a doula, in the salary tools that you're using. We have looked, there is nothing that exists that is comparable. And it is really difficult for us to know how to proceed or how comfortable we will be with some type of rate in a way that we would sign contracts in the end of June. And I just wanted to raise that because it feels like challenging from an equity standpoint for some models, which also happen to be smaller BIPOC models, in the case of a couple of them, to go through this process and be finalized in terms of a rate, maybe perhaps a year before some other models are. And I worry again about the equity of that and being able to see sort of the comparison of how the rate is set for these smaller organizations versus the bigger ones. We don't have visibility into what the rates are across the board. And so I just have some concerns, and I just know from our standpoint, we may learn about the rates and the amounts that are kind of, and the equations and the calculations that are used for salaries, and we may learn that in May or June. If we aren't comfortable with that, it may create a situation where we don't feel comfortable signing a contract. And I really don't want to put our staff and our home visitors in that type of situation. And to me, it's very much an equity concern that I have. I realize that this is complex, and I am not surprised that getting this to be completed into the finish line by the end of June is really challenging. I don't envy you at all. What I worry about is being one of these first horses out of the gate who have no idea what's going on behind us and being locked into a contract that we are committed to for a year. When I know we happen to be a unicorn. We love being the unicorn. That's what makes us good at what we do. At the same time, I would prefer to know that we're not totally being treated differently than other groups. So I wanted to raise that to the HVAC committee. I'm not talking just about it from the standpoint of my particular program, but I think that it does have an influence on sort of the overall work of the rate setting process and integrity of the process too.
Thanks, David. We hear you, and I think what you all know is our timelines have continued to evolve over time, and I think I'm sure the next few months, those are our goals. We are shooting for those, and sometimes we're overly ambitious, but we're going to still try to get there, but knowing it requires our partners to also be there for that. Yes, hear you. Other thoughts or comments? We wanted to make sure we had adequate space in our agenda to hear you all. Again, we know the challenge. No one's seen numbers yet outside of the surveys that we've done to fully understand and know and project forward. So I get that, but also want to just create space for you all for a little longer before we move to our next conversation as well.
This is Marilyn, and I've shared this before, but I want to bring up again the impact with what we've received so far, the impact of rural communities like ours, and the potential impact to our work with our tribal work, so our work with Tatawak's Birth Justice Center, and work that we have. We've spent 12 years together in our relationship, and, we have 2 nurses serving with them, and the impact to a community if it means we can't serve them. When we've, I've heard this many times in tribal work, you can, like, if you do not maintain the trust with them, it'll be another 10 years before you're going to be able to implement again. And as we continue to be a part of their plan to serve their community, I'm very concerned with that. And it's one of the, I know unintended, it's a potential unintended consequence. And so I just want to raise it again.
And Marilyn, to clarify for you, is for you, when you talk about that partnership, which has been amazing and beautiful, is it primarily the exemption you have for reduced caseload for that population that you're thinking about? Okay. We have and will continue to think about and focus on what our tribal partners need, and we are aware of these unique partnerships and the existing exemptions and exceptions for when that happens. And there's no intent to shift that through this rate setting process. So just wanted to clarify that with you, is that we have noted and know when those partnerships have, I can't remember what the NSO calls it, Marilyn, but a modification from the typical standard. Yeah, thank you, variance. Yeah, so we're tracking those as part of this, and it's not our intent to reduce anyone's contract, period. But just know that that's not in the plans at all as well. Cynthia, I see you as well.
Yeah, thank you, Laura. I appreciate everybody's comments. I had a question around like what the rate setting is actually going to look like at the end, because I have shared this in the past. It does feel like we're building a road and we don't really understand the destination. So if there's any like clarity you can provide on like what it's actually going to look like or what it's going to be based off of, that would be really helpful, especially as we're providing the worksheets and the rates. It just still feels a bit ambiguous about what it's actually going to look like.
Thanks, Cynthia. I don't know that doing that fully right now, but I will be that helpful because I'm thinking on the fly a little bit. But what I'm hearing is the need to give a little bit more picture understanding of what the payment difference will be. Like, what's the implementation going to look like from our cost reimbursement approach to a case-based approach using a case rate. And I will tell you, I don't totally know either. We have some examples from other parts of DCYF, but the steps in the process have been to set the rate and then determine the payment methodology, which there can be some different ways to do that. And we aren't landed on that yet. We have some ideas and that we've started to sketch some ideas out, but we're not there. So what I'm hearing as part of our partner engagement, our LAA engagement, is that's a next step we need to take too, is making sure that it's we're starting to project, describe, and ask for input on those pieces as well. Cynthia, is that helpful? Is that kind of what you're asking for? I don't feel like I'm prepared to do it now, nor will it probably be that helpful if I try to do it on the fly, but we could do that in the coming meetings as well.
It would be helpful to have the information that you can provide, but yeah, I hear that it's coming and that there could be different ways to approach the reimbursement. Is that what I'm hearing?
Yep.
Okay.
And by that, I mean, we will find a way, but we have a couple of ways to choose from that are within what DCYF will, I think, allow. So, but we haven't presented those at all in any of our meetings.
Okay. Do you have a sense of when that information would be available to present?
Oh gosh, no, in the next month or two, I'm hoping. Cynthia?
Okay.
That's what I would say, because we're trying to get to the rate and then the payment, and they're linked, but they are kind of two separate decisions along the way. So thank you for pushing us on that. All right, Trista?
so this isn't anything that I need an answer on, but I just wanted to share with you guys as we've been going through this process of, like, we already have to have our budgets done. I think it was 2 weeks ago, because they go to our board. I think they went to our board last week or they go this week. So, with the letter that we got, I provided that to our fiscal people, and they tend to be overly cautious, which I appreciate because they've gotten us through many, many audits. So I said to, our CFO, based on that letter, I think, you guys gave us a 7% in January. I was like, I'm thinking 7% for July 1, an additional 7%, I said, I don't know, I'm just sort of guessing. And I just wanted to let you know that rate setting in other parts of DCYF have created rumors in this part of the work, meaning like our CFO just totally shut it down and was like, no, DCYF promised on our what we call youth services in our organization, which is essentially the ILP, like people who are, transitioning out of foster care. We have a lot of services in that area, and they got a very similar letter that they should be expecting some sort of rate increase with the restructuring, and actually they ended up having decreases. So it's created, I think it's from my perspective, I think it's different in that I know that the money has already been allocated for this rate setting process in last year's legislative session. I know that, the expansion has already been set aside. I know that I trust that the money's there more, but I just want to let you know the impact in the field on this, like the unknown, that a lot, I'm guessing we are not the only organization that's like, well, DCYF screwed us over here, so we're not even going to take the chance over here. And I know that's not fair to you guys because you're not necessarily involved in that work, but I'm just letting you know how the rate setting increases have like impacted our accounting department, for example, and planning. So just FYI.
Thanks, Trissa. Maybe we'll just spend another minute or two here. I know there's another topic for us to get to today as well. I'm gonna just check in, see if there's anyone else. I do know that we have someone here that's on an iPhone, and maybe our community engagement folks have already asked that person to chat in who it is, so we make sure we get the right attendance.
It's still Erica, Laura, sorry.
Oh, hi, Erica. I thought you were on a plane by now.
Well, I am. I'm about to head off.
Okay. All right, we know we are continuing to work on our communication and appreciate feedback that we got and the need to get to the payment methodology approach and the impacts of delays and timing and all of that. I hear you on that. I'm hoping I didn't miss any other key themes here as I was listening. Okay, gonna check in one more pulse check. Any other thoughts here? I did want to go back to the question that was on the slide because Adrian and I are co-leading our ad hoc costing work group. And we've kind of been grappling with like, what do we do? We don't have a ton of traction right now that we can move with FFPSA or Medicaid. And so our question was, is there anything you want that group to tackle or to do about the rates work? So I really like any thoughts that you have on that because we've pushed out, we were going to meet today, but then we said, well, we're going to talk about this during the meeting. There won't be really anything different to talk about ahead of it. So if HVAC wants to assign something to that group, that would be helpful for us and our thinking for a next conversation. That would be the last question I have for you. Go ahead, Trissa.
Laura, would it be appropriate for the cost group, you can tell me if it's not, for them to take on the, some of the concerns that we talked about regarding the fentanyl home visiting work?
Specific to some of the enhancements and the time and that kind of thing, Trissa?
I'm just still concerned about like slots and caseload and amounts and how that because like we said, as everybody said in that section, it's a harder group to work with, you know. So that was just an idea that popped
That's
into
an
my
idea. Yeah, I appreciate that. Any other thoughts or do other people have feedback about that idea or other ideas that you might be holding?
Well, thank you for that. Laura, if there are any other thoughts or questions, please feel free to put those into the chat. Even though we may not have responses for them today, we definitely will take those questions and get back to you with responses as we move further along the rates discussion. So last topic for today is expansion. And this will be kind of a tag team effort between Renee and I. If you could go to the next slide, and I will hand it off at the beginning to you, Renee.
Hi, everyone. So kind of in the midst of all of this, planning going forward with the SB, I can never remember all the numbers, but fentanyl support and the rates work. We're also planning for distribution of another $1 million for home visiting slots, as I think Erica asked earlier in the year. So that we spent a little bit of time talking about that last meeting and asked you some questions. So part of what I'm going to do today is tell you what you told us and pretty much allow for some reflections around that. So just a quick reminder. So some of these slides, and I have a lot of slides in here that I'm going to breeze through, partly because they were in last month's meeting. But you can always refer to them as reference. So we kept them in because we felt like that was important enough for you all. It's $1 million. We expect that to end up being fewer than 80 or to 100 slots, but it's all contingent on rate setting, and the dollars are going to be administered through rate setting. It's to be effective July 1st. It's using state funds general. And our HVSA funds 9 models, those 9 models are all remain eligible in this process. So we can go through the next slide. This is just a slide depicting our current array of 46 LIAs, 10 of whom are BIPOC led. And we have budgets ranging in size from $1 million to $169 million. And I think you've heard kind of comments over the day, really reflecting the diversity of organizations that are funded through the HVSA. And so that this depicts that a little bit. And I'm just going to go to the next slide right now. But I do think it's really important, that size of budget. It's important to know that the median is 6.6 million. So that means half of our programs are sitting in organizations whose budgets are 6.6 million or less. And that's pretty small for an organization these days. So it's important to kind of get that in your head. And this is our history. I am not going to walk through these, but these are the last 5 procurements that we've administered through the HVSA. And you can see on the far right column, the resultant model array, but the middle column, the fat column there is kind of what we were aiming for in our procurement parameters. And what we're hoping to get a little bit more from you as kind of guidance on that middle column. Go to the next slide. And again, you can always refer back to this when you're kind of thinking about this later on. And typically what we do when we do a procurement is we set parameters ahead. So that helps applicants know what we are looking for. And I know from having worked in community-based agencies, it feels like an awful waste of time to be writing an application when you feel like maybe if you're not what they're looking for, why bother doing the work? And so really trying to help the communities understand what it is, where priorities might lie to help decide whether that's worth the time to plan for an expansion and then write the application. So, because we know it takes a lot of work. So these are what we've done. We've used installation stage, whether that's, we're brand new programming that doesn't exist before versus expansion, what types of models we might want to focus on, any kind of priorities based on geography or population, and then anything else. So we try to depict some of that in here to help tailor, $1 million doesn't really go very far in programming. And so how do we decide how to best use those dollars and then inform programs so that they know whether or not it's worth it for them to apply. So we asked you all about a lot of questions last meeting, kind of trying to help us prioritize some of these areas of parameters. So go to the next slide, please. And I'm going to share with you, I think, so what I decided to do was start with the end first, which is we asked you, we went through all those parameters with you and asked you to vote on what you thought. And here's when we asked you what you thought were the top 3. This is what the 12 folks who were not TRIO members and who were present in the meeting gave us feedback. So out of 12, 11 of you felt like the program specific population specific priority was really the most important. And then you can see followed by geographic service area. So those were 2 clearly standing out in terms of well over half. And then from there, it went down to looking at setting aside dollars for installation stage or like inviting HVSA. And I'm going to go into all of these in the next deeply, but I wanted to show you how you ranked kind of each of those priority areas. And so finally, with model array being the lowest, and then other, which we didn't really define. So go to the next slide, please. So here is, if we were to, when we asked you specifically geographic areas, and we used examples of prior procurements, if we were to prioritize locales, school locales, which is slightly smaller than county, but it's a population size that's kind of measurable. There was really not a lot of guidance from you all in terms of wanting to specifically say, we think those locales having documentation of higher risk or higher child welfare involvement or fewer home visiting slots, or even a combination of those. We didn't see that prioritization from you. And so go to the next slide. I just wanted to remind you, this is how we're distributed right now. So again, without really, not any kind of firm direction. You can see where we are. We don't quite have statewide representation. We have a lot of slots in a few places, which kind of follows, I think, school free and reduced price lunch kind of where some of our slots might align. But that's just me throwing information out there that I don't really know is true. So we can go to the next. I'm trying to be fast here too, because I also know we kind of promised that we weren't going to go super long. Here's another batch of information that would be useful is to look at these. This is a map on the left of areas in the state that have the highest rates of child maltreatment really screened in, families screened in. And you can see that these are all school locales with the darker red being higher. And again, it's the highest, the 23 highest. So you can see where some of that weight might be if we were to focus on a geography. And then to the right would, and you can see a lot of extremely rural communities here. And then on the right would be DCYF offices where we see the highest rates of placement in services for Native American and Black African children. So, and here you actually see some of the more urban communities standing up. So it's just really an interesting array of what's going on in the state. And one of the things we are actually looking at doing is also trying to figure out how to overlay this with some of that fentanyl work that's going to go forward with that other pot of money. But I just wanted to share that this is kind of looking at things geographically. Next slide, I think so this was again your highest priority area. Next was population specific. So when we asked you specifically about populations we should focus on, well, there's some really good guidance here. It looks to me like one of our more recent applications, we asked to folks to prioritize 4 groups: American Indian, Alaska Native, Black African families, Hispanic families, and immigrant refugee families. So there was a desire, sounds like, to prioritize, but to prioritize 4 as opposed to 2, or not to prioritize at all. So again, that was the second highest area of interest from you all. And I wanted to just include here by way of background, what we expect all of our programs to prioritize. And again, we can go to the next slide. It's just a list. It says we ask our programs, this is in our contract, that families represent at least 2 of these characteristics already. So not every family has to have every characteristic, but that, or that a program necessarily has to focus on any one of these areas right now. It's just that we want to make sure we're serving families who have higher needs, because we have limited dollars to go around. So we want to see services to prioritize towards these groups already. And we always communicate that when we procure. I'm going to keep going, and I'm sorry for just pushing on this. Did we just, yeah. So that, okay, so now we're getting into where, much fewer of you felt like this was important, and that kind of bears out in the results here in the Zoom poll, when we asked if we should set aside funds for an installation program and then or expansion. About a quarter of you said, yeah, that's a good idea to set aside, and again, this is only $1 million. And so about a quarter of you thought that was a good idea to set aside funds for installation. And a third of you thought only expansion, no set aside. And then another third of you thought either's fine. It's a little complicated to run a procurement that includes both. It's a little confusing to the field, but it's doable. We've done it. So go to the next slide, which is, we've done this when we only had $1 million in the past. We only offered, we invitation only, and said this is an expansion, and it's expansion only for HVSA funded programs, and only programs that met certain performance criteria. So, and again, we got about a third of you said, don't limit it. A quarter of you said, yes, you should limit it. And then another third said, either way's fine. So I keep looking at Dila's smiling face, and it makes me smile. So I just want to say your picture. I see your smile, and it makes me, oh, okay. I got distracted by that, and I got to stop looking at your picture. Anyway, but we asked again, if we were to limit by invitation only, where do you think we should limit? And should we limit based on performance and enrollment? No. Then I have that little table below. Not only one person says, yeah, look at enrollment. 2 people said retention. A little, almost half said retention and enrollment together, or one or the other. And then another, so there was, yeah, here, maybe it was using those criteria, but again, this is only only a third of you even thought we should use this as a criteria at all. So, and then going forward, I think the next slide is model array. And here it's really great. It's very direct guidance. Don't use the model array, which is interesting because in the past we've been asked to set aside certain funds for our non-PAT, non-NFP models. And this, we didn't get that kind of guidance here from you. Here, no set aside for model. And then I'm just thinking, what's the next slide? Oh, and I just wanted to show you our array. So again, you can go back if you have questions about that. So next slide, you can just see how we fund that array. So I just wanted to again remind you of, this is what we heard from you, is that really population specific priority is important. And there was some clear areas of preference for that. Next came geography, although we didn't get kind of where that preference for geography, although you thought geography should be a consideration. Those were the two highest, then following by performance and installation. So I just wanting to remind you about that. And then the last thing we asked you about in terms of this was really a process oriented question. So the next slide is, you know, when we go through the process of setting priorities, should we only consider applications that offer those priorities versus give weight to programs who say we offer a geographic and or a population specific priority? Would we only accept applications who say that's what they intend to serve? Or would we just give priority points to those folks? And it was very clear here, don't limit to those folks who only propose to serve, but yes, give priority to those in terms of points. So that was helpful guidance. So I just want to say, I don't know if you want to reflect on all of that and give any feedback based on, and some of you weren't here at that meeting. And so it's like you're hearing from, you know, your voices of your peers, and maybe your voice isn't reflected in this, but I want to go to the last slide. I think, I'm not sure even if it is the last slide, but the other thing to be considering is we are working on the rates. The rates are expected to impact and be administered through all of this. And so that's still to be determined. And so that we're kind of, there's a little bit of a dance that we're doing right now on how to move forward with expansion when we're not quite finished with the rates work, as you've all heard from us and your peers. And then this ESSB 6109 could impact the same exact pool of LIAs. And that's expected to happen concurrently. So we're trying to figure out, well, how do we integrate those two, or if we are supposed to at all? And then we have McVie changes that we're also looking at that might impact where we're going kind of forward. So I think that's the last of my slides. And then we can just have discussion at this point. So and Adrian is saying we should have the discussion. So I don't know, Adrian, if you think we should go, back to if it's helpful to look at a slide or just have the conversation. And so,
I think, you know, for those areas where, and even for the ones that you have a real clear path, you know, you still have people saying something else, even though if it's one person, I think it will be great still to have the conversation to understand the rationale, because that may shift also what I said, you know. Right. Well, I just think we just have to have the space for it, you know.
Yeah, absolutely. And this is the space. So go for it, Gretchen, and then Trissa.
I know one of the child maltreatment rates are always so tricky, Renee. I know this is something we look at every year with during Child Abuse Prevention Month, when we share data with our local policymakers. And there's always this lag. I, though, really want to encourage trying to either being cautious about using that or finding some more current rates, because I know that, I mean, just there's been communities that have had huge spikes, and others where, you know, like for example, in 2022, the state average actually fell, but there were communities that had, you know, increases, significant increases. So I don't know, just something, I guess I just want to caution against putting a whole lot of weight into that unless we can get some better numbers.
Yeah, thanks.
So as Adrian was saying, like, you know, I want to explain why I have this particular soapbox of using school districts versus counties when looking at location. So Grant County, for example, has 25 funded home visiting slots, but they are in the southwest corner of Grant County, and they are primarily only for like Royal City and Mattawa. And I don't expect you guys to know those communities if you don't live in Central Washington, but they're very teeny tiny. They're far south. And then there's absolutely zero home visiting. Well, I think there's like 15 early Head Start slots in Moses Lake and in Ephrata, which are pretty too close together. Now, those are also in Grant County. But the thing is that like they are 100 miles from each other and a 2-hour drive. So when you use county, especially when you're in rural areas, I would suspect this is even true for urban areas. When you use counties, it's not a good number of understanding what communities are actually being served by home visiting. So Moses Lake is one of the most rapidly growing cities in the state of Washington, and it has a lot of issues, including fentanyl issues, although it wasn't high on the CPS or removal screen, but like it's a poor community. And I think one of the things that I would say kind of about it specifically, I was just talking to my uncle, he's a lawyer there, and he was saying that like they project 10,000 additional homes being built in Moses Lake. It has the highest growth rate in the state because they have such low electricity rates, like some of the lowest in the country, that a lot of like Microsoft and other places have these giant, server warehouses, and you would think, oh, well, that's highly paid workers. It's not. Like, it's just people doing maintenance, it's still lower wage workers, so it's not like work is coming in, but it's not higher end. Anyways, my point is they have 17, the city that's like 60,000 people and supposed to increase even more has 17 home visiting slots. And whereas Royal City and Mattawa, which are teeny tiny, like maybe a couple thousand between the two cities, have 25 home visiting slots. The disparity in that county alone is significant. And again, there's no way that the CBHA who have the 25 slots in in Mattawa and Royal City, they're not going to drive 2 hours to go to Moses Lake. So I think that's why Renee has heard me on this soapbox many times. That is why I think school district needs to be the direction for locality, because I think if you don't go that far down, you're not getting an accurate picture of what communities actually have home visiting.
Thanks, Trista. I think that all of our needs assessment work now is put out in that. Yeah, is put out to the school locale area because it you can mask need by using the county. Or, yeah, whatever. Anyway, anyone else have thoughts or input? And Nellie did say that we were thinking we were going to try to end early, and I actually had it in my head that we were ending by 1. So I was stressing about giving you all this information. So I apologize if I'm impacting your lunch. Feel free to get that. Well,
Renee, the money is July 1. Do you guys have any sense of when you're going to put it out?
Great question. I think, yeah, thanks, Trissa. Can I pay you next time not to ask that question? I think, yeah, I'm actually trying to, we're recruiting for somebody to help us on our team with this work. As you can imagine, there's a lot happening, and it's all kind of happening all at once. And there is some dependency of rates work. It's hard to say this, we're going to pay via rate when we don't have, how to communicate that. So, without going into the ugly detail, we're trying to have these things dovetail, and it's hard to make them dovetail when we're not quite where we would like to be with the rates work. So yeah, one of the things we're aware of well, and it's also the fentanyl money is also supposed to be effective July 1st as well. So, and we're now at 10 weeks from July 1st. So, yeah, I'm not really have a good answer for you.
Well, I would just say from both the perspective as somebody who's like an HVAC member here, but also an LIA leader, I don't know that I really would want to apply if I didn't have a good sense of like where the rates are sitting. Like, I mean, as you can imagine, as an LIA leader right now, I was talking to Marilyn, we got put in the same group. We didn't even answer the questions at the beginning because like we know each other so well. But anyways, like, as Marilyn and I were talking, like, our budget is a huge question mark. She's an FP, I'm Pat. Like, we don't know. We don't know. We have lots of plans. We have lots of hopes, and yeah. So I think I personally, from, I think both an ethical standpoint as an HVAC, as somebody here on the HVAC, but also as an LIA leader, I personally think don't do it until you have the rate set, but people might feel differently about that. And I don't know. I know Erica had expressed at April's meeting, no, this is April's meeting, at February's meeting about concerns regarding could the legislature snatch it back? And I don't know if that's true or not. So I guess that affects timelines as well.
What we're trying to do is that's kind of why we're asking you these questions so that we're ready to go once, so that we're ready to go. I guess. And there's a lot of things we can do to get ready to go with, so that once things are clear, we'll know. But I also know that, how long it takes to run a process and have it be fair and inclusive and allow for communities to really consider whether they want to apply or not. And you can't just, do a 2-week turnaround kind of thing on this. So it's another tension. We live with a lot of tensions. So, thanks for your thoughts.
I know I said this last time. I do appreciate all the hard work you guys do. I know that these are really complicated decisions to make and that this feels like the most hopeful, but also the most not hopeful I've ever felt being funded through the HVSA. Like it's so hard. And I just want to hold space for the fact that I know it's hard for you guys. And whenever I push back on you guys, it's not because I don't love you. I do. It's just because I want to make sure that all angles are looked at.
Well, and we need the voices, right? So we don't, we appreciate them in all venues in which they are delivered. I will say that. I appreciate the one-on-ones I have with people. I appreciate it when you all express views in public meetings like this. Yeah. So that's part of what the partnership means, right? And I think we take the partnership pretty seriously. So sometimes it might not feel like that, but I think we wear the tension. But we wouldn't if we didn't hear from you. So
I think there's also more to come on the topics we discussed today. Not that our next HVAC meeting will be the only time that you'll hear about it, but our hope is to have updates then too, and engagements between now and when we meet again in June. So really, really, really appreciated this HVAC meeting. I feel like we had enough time to kind of dive in and to talk and to gather information, to hear specifically from you, to share the information that we've had. And again, as things come up, I was wondering, Emily, could you launch the poll again? Yes, there was a poll. So we're just going to launch the June meeting poll again. If you missed that for HVAC.
Did the results show up? I'm not super. Okay, cool.
So, again, we'll have communications between now and then because the work is continuing. Like we are learning new things and moving forward with things when we meet, and we meet regularly about multiple of the topics that we've talked about today during the week. We are having our June meeting. It looks like at this point, we have the most votes for the 13th of June. So we will most likely be meeting on the 13th of June. It will be a hybrid meeting. As far as location, we will get back to you. We had an offer during this meeting for a a site that we want to definitely explore and see if it's a possibility. We would love to meet in a community space. So that's what we are kind of exploring, and we'll get back to you on that as soon as things are confirmed. And then we'll also be sharing some agenda items for that as well as we get a little bit closer. I think you can see some of the ones that will be coming up as topics during our time together. We've shared some of that today. So we'll be following up on most of what we talked about today in June. Also get an opportunity to do our fiscal update. We've done one so far. We are due one before we are done with the meetings for this fiscal year, state fiscal year. So we will be doing that as well. So just wanted to express again gratitude for the attendance. We had quite a few guests, which was good and exciting. Hoping that we'll continue to have more people join us. Thank you to all of you who are regularly here for being here again today. I just wanted to give an opportunity for any kind of last minute thoughts before we wrap up. I know there's quite a bit of content in the chat, which we will save. And if there are questions that we did not have a chance to respond to, we'll be able to get back to you with responses to those questions. So again, just want to give a couple of minutes for any last minute thoughts. You can do that out loud or you can do it in the chat.
If Nellie, if we have a question about what's in the written report, should we get back to you, or who should we get back to with questions?
If you could get back to me, that'd be great. And if I don't answer, I will funnel it to where it needs to go. All right. I typically try and do and hum the Jeopardy theme song in my head as a way to remind myself to take a minute to give people an opportunity to formulate questions. So I've done it 3 times. And so I'm going to step in and say thank you again so much for being here today. We have our reflection survey link. If you could click on that and complete your survey, I think we'll also send it out with a follow-up email. So if you're unable to do it now, you will get a chance to do it again when we send our follow-up email. With that, we were giving you a gift of a half an hour that we're hoping that you will use for lunch, since we did not plan for lunchtime for you during the meeting. So that you'll get some of that in. Enjoy the sunshine as well at some point today for those of you who are having sun. And again, thank you so much. And we will see you in Spokane at a to be determined location, either in person or virtually in June.